Dr. Cicero Coimbra earned his medical degree from the Federal University of Rio Grande do Sul in 1979 and holds specialist degrees in internal medicine and neurology. He completed a fellowship in pediatric neurology at the Jackson Memorial Hospital of the University of Miami and completed postdoctoral training at the University of Lund in Sweden. He was associate professor in the Department of Neurology and Neurosurgery and is the founding president of the Institute for Research and Treatment of Autoimmunity in Brazil. Dr. Coimbra's clinical work focuses on neurodegenerative and autoimmune diseases, and he currently seeks to deepen and share his knowledge about the causes of the worldwide exponential rise in the prevalence of autism spectrum disorder and other neurodevelopmental disorders. Dr. Coimbra is the founder of the Coimbra Protocol, which uses high therapeutic doses of vitamin D to treat autoimmune diseases. This protocol is now used in at least 13 countries by over 200 doctors who have been trained by Dr. Coimbra or other trained physicians. The treatment of high doses of vitamin D for autoimmune diseases was developed based on the results of the Human Genome Project. These findings led to the identification of polymorphisms affecting the genes necessary for the immunomodulatory effects of vitamin D metabolites in patients with autoimmunity. Individually adjusted high doses of vitamin D were found to counteract the resistance resulting from those polymorphic changes. Patients from several countries have greatly benefited from this protocol. I welcome Dr. Coimbra today to tell us more about it and these amazing benefits. How did you first become interested in vitamin D as a neurologist and a practicing medical doctor?
Okay, by the year 2000, I had my first appointment with a patient with Parkinson's disease, and he had several spots of vitiligo on his forehead. At that time, I was interested in therapeutic approaches that could enhance the synthesis of neurotrophic factors in brain tissue, as these factors could prevent neuronal degeneration. So by that time, I had read about reports on the stimulatory effects of vitamin D on the production of neurotrophic factors. So trying to help that patient neurologically, I prescribed 10,000 units of vitamin D in the form of cholecalciferol to see if his Parkinsonian symptoms could be better controlled. That daily dose was already established as no adverse effect level. When he came back 6 months later, his neurological state was about the same, but the vitiligo spots had almost completely disappeared. Then I searched the medical literature and found about 300 scientific papers discussing the importance of vitamin D for the immune system. Today we have more than 500,000 papers on that subject. That was when I started prescribing 10,000 units of vitamin D daily for patients with autoimmune disorders, not only MS, but mainly for MS patients, because, as you know, I'm a neurologist. And I was amazed. The results were impressive just by giving them 10,000 units of vitamin D. At that time, I found a paper published in 1986 by Goldberg and co-workers from Boston, reporting a reduced frequency of relapses in MS patients taking about 5,000 units of vitamin D in the form of cod liver oil. And they demonstrated it was just a simple research. They compared the frequency of relapses before giving them about 5,000 units of vitamin D, and after during the period when they were receiving that amount of vitamin D. And they found a reduced frequency of relapses. So that was the beginning of everything. So this first presentation shows that vitamin D is essentially synthesized in our skin when we are exposed to UVB light. This occurs when the sun is high enough to produce a shadow that is not larger than our stature. If you are living in big cities, working in a confined environment, and are not properly supplemented with vitamin D, then you're definitely vitamin D deficient. Vitamin D is actually a precursor of a steroid or hormone and can be turned into its correspondent active hormone in several of our cells, not only in kidney cells as most people believe. Okay, dark-skinned individuals required about 5 to 10 times longer exposure to sunlight to produce vitamin D compared to fair-skinned individuals. So dark-skinned individuals living in high latitudes are likely to develop severe vitamin D deficiency, and they are more susceptible to a wide range of apparently unrelated diseases like tuberculosis and hypertension. So at least in Brazil, the sunscreen was launched in 1984. So from that moment on, there were a lot of propaganda trying to make people to avoid any minimal exposure to sunlight. And this had two consequences. For instance, if you use a protection factor of 8, that blocks approximately 95% of production of vitamin D. And if you use a factor of 15, then you approximately 99% of the cutaneous production of vitamin D will be blocked. So in addition to that, the second consequence is that sunscreens can contain aluminum hydroxide-coated titanium dioxide nanoparticles. And those nanoparticles can penetrate the intact skin. And aluminum is extremely toxic metal. That vitamin D is not actually a vitamin, it's a steroid hormone. It converts into a hormone in several of human cells, and it's needed by nearly all cells for their functions. Low vitamin D levels play a role in the development of many diseases. So this is the number of, just a few examples of diseases that are affected by the level of vitamin D that a person has. And you see, for general human health, you have almost 2 million papers already published. This led us to these publications by Stumpf in 2012. He said that vitamin D is as fundamental as the sun and the closest we have to a panacea. Regarding the immune system, we have more than 500,000 publications available in Google Scholar. And here is just a slide to demonstrate how important vitamin D is for the immune cells. Suppose that you have immune cells that has phagocyted Mycobacterium tuberculosis. So it's within the cell, and the cell has to destroy it. In order to do that, Mycobacterium tuberculosis, as any other bacteria, stimulated the stall-like receptors, and as a consequence of that, messages are sent chemical messages are sent to the nuclei of immune cells. And this makes immune cells to express the 1-alpha hydroxylase, which turns the 25-hydroxy-D to 125-hydroxy-D, which is the active form of vitamin D. And this active form of vitamin D stimulates the vitamin D receptor. As a consequence of that, catalysidins are produced, and these are compounds that destroyed virtually any kind of microorganism that has invaded our body. So we see how important vitamin D is for the immune system. If we don't have vitamin D, then the bacteria, like a Mycobacterium tuberculosis, will remain alive within the immune cells. If we look for vitamin D and infectious disease, this slide shows that by 2021, there were almost 300,000 peer-reviewed publications on the functions of vitamin D in the immune system. And today, in 2025, we have almost 400 papers published. Regarding infectious disease, you see this large number of publications showing how vitamin D level is important to control all of those infectious diseases. I would like to show you an example of that by presenting Dr. Auguste Rollier. He died in 1954. He was a Swiss physician who treated tuberculosis in the first half of the 90s, at a time when no effective antibiotics were available to combat that highly contagious chronic disease. And he built up in the Swiss Alps at 2,000 meters above the sea level. He built up 36 edifications with large balconies, as you see here. And he used to treat tuberculosis by exposing his patients to sunlight. And the reason why he had to be 2,000 meters above the sea level is because he wanted to be above the clouds, so that he would have sunlight throughout the year. So the treatment consisted of daily escalonating solar exposure. His buildings were called sanatoriums. One sanatorium situated in Davos appears in the novel The Magic Mountains by Thomas Mann, who was first published in German in November 1924. This is an example of his results. On the left side of the slide, we observe a 4-year-old patient with 34 foci of osteitis, adenitis, like we see here, numerous ulcers, as this one. I would like you to pay attention to this one, and tuberculomas affecting his right forearm. The patient also presents with advanced tuberculosis affecting both feet, the right hand, the left lung, and the abdomen. We call it peritonitis. He was extremely thin. He had lost a lot of body weight, and at a level that we call cachexia. His lower left shoulder suggests that he had also had rickets. And it's important to say that rickets children with rickets frequently died because of tuberculosis. And at some point, some medical doctors thought that tuberculosis and rickets had the same origin. On the left side, on the right side of the slide, we see the same patient 1 year later, healing of ulcers, reconstruction of bones, muscles, and the general condition. And you see that that ulcer is now healed. At a time when the importance of vitamin D for immune system was not known, Dr. Hollier credited the success of his treatment to exposure to sunlight and to the pure air of the mountains. The effectiveness of solar exposure in treating tuberculosis is evidenced by the establishment of sanatoriums in various locations worldwide, including the mountains regions of southern Brazil. However, at some point, the sanatoriums were fitted with glass windows, and glass blocks the UVB rays, which are required for vitamin D synthesis in the skin. As a result, the sanatoriums ceased treating tuberculosis and were closed at a time when the first antibiotic for tuberculosis treatment, the injectable streptomycin, was introduced to the market. Now sanatoriums turned into hotels at the Swiss mountains. So low vitamin D leads to low calcium synthesis, allowing microbes to remain alive within the immune cells. And that leads us to the Trojan horse mechanism. We see here the structure of the blood-brain barrier, including the astrocytic podocyte participating in this barrier. And we see that some virus, like HIV virus, when you have low levels of vitamin D, they are not destroyed by the immune cells. And when the immune cells penetrate the blood-brain barrier, because they have the mechanism, those cells have the mechanisms required for this penetration. It's carrying virus, so that's the way when infected, the brain becomes infected by HIV and several other virus, probably, like some types of severe measles and like in polio, you also have the same mechanism. This is called the Trojan horse mechanism, because the virus enters the brain within the immune cells, and by doing that, they bypass the blood-brain barrier. In September 2018, the WHO called for urgent action to end the tuberculosis epidemic. Prior to the COVID epidemic, tuberculosis was the deadliest infectious diseases. It was killing like 2,000 people per year worldwide, per day. The combined use of multiple antibiotics to combine the antibiotic resistance has shown limited effectiveness nowadays. So autoimmune disease, this is an important issue to our protocol. Autoimmune diseases are almost always triggered by stressful life events, and managing emotional stress should be regarded as essential for the success of all therapeutic approaches, not only related to autoimmune diseases, but also to several other diseases. So then we are merged into this vicious cycle when emotional distress leads to reduced magnesium, and as magnesium is required for vitamin D activation, then you have reduced vitamin D activity, and that's increases the possibility of acquiring an autoimmune disorder. And when the patient has acquired an autoimmune disorder, then these contributes to deepen the emotional distress. So reduced magnesium also causes excessive reaction to daily life problems and increases emotional distress. So this emotional distress disrupts the epigenetic control of dirty genes that we call the SNPs that we all have. We all have dirty genes, but they are usually switched off since prenatal life. And when we have a high level of stress, this in a way switch on those genes. So if you look for autoimmune disorders and stressful life events, we know we today have like almost 12,000 papers published. This is an example association between stressful life events and autoimmune disorders. Now going to vitamin D and autoimmune diseases, the issue of vitamin D and autoimmune diseases. We have more than 200,000 papers published. And so all those autoimmune diseases have tens of thousands of papers published relating them to low levels of vitamin D. So how vitamin D works in autoimmune disorders. An autoimmune disease is mediated by abnormal immune response, which is called Th17. There are almost 300,000 papers showing that this is the mechanism involved in the origin of autoimmune diseases. And vitamin D inhibits Th17. We have more than 3,000 papers, showing the property of vitamin D related to inhibition of Th17. You see, it suppresses the Th17 cytokine production. This is one example of these publications. So this this slide is to review the metabolism of vitamin D within immune cells. Vitamin D, cholecalciferol, is hydroxylated in the liver and released in the circulation. So vitamin D, 25-hydroxy-D, enters the cell, undergoes a second hydroxylation within immune cells, and the resulting 125-hydroxy-D stimulates a VDR, vitamin D receptor, that inhibits Th17 programs and stimulates the proliferation of regulatory T cells. Okay, this is the same slide. So vitamin D and Th17, as I told you, we have like more than 30,000 publications. And how we adjust the dose of vitamin D. Here we have the parathyroid cells, a cell of the one of the 4 parathyroid glands that we have close to our thyroid gland. And the vitamin D that is activated in the liver also enters the parathyroid cells. It's activated and stimulates VDR, and the stimulation of VDR by the active form of vitamin D inhibits the production of PTH, parathyroid hormone. So what we do in order to match the level of resistance that a person has to vitamin D is to measure PTH before the treatment and after 5 months of treatment. So when we increase PTH, when we increase vitamin D, PTH decreases. And the goal is to decrease PTH to just above the lower level of the reference range for PTH. So PTH inhibition has two advantages as concerned to our protocol using high doses of vitamin D. It shows the level of individual resistance to vitamin D, and if PTH is not decreased below the lower level of the reference range, then this assures safety. It means that we are pretty sure that there will be no intoxication. Intoxication meaning increased level of calcium. So this is.
Before we go on, are you going to talk a little bit more about what vitamin D resistance is? Because we didn't quite go into that part. I know you've talked about it before in some of your presentations, so maybe you already have it in your slides.
Okay. I can give you an example. Patients who have autoimmune disorders, they have polymorphic changes affecting any combination of the 9 genes that is required for vitamin D effects. So we don't know the level of resistance that a specific patient may have. So we have to test it. So we give a testing dose that could be something like 1,000 units of vitamin D per kilogram per day. And so vitamin D starts increasing, and it takes like 3, 4, or 5 months to level off. So we measure PTH before starting vitamin D, the supplements with high doses of vitamin D, and after 5 months. So at the end of these 5 months, we see how much vitamin D, when we increased vitamin D, how much PTH decreased. That was what I was trying to show you when I showed this. Suppose that this is the level of PTH that you have before the treatment, before taking 1,000 units of vitamin D per kilogram per day, and this is the level of PTH that you have 5 months later. So it should be just above the lower level of the reference range. If it has increased below that level, so I have to decrease the daily dose of vitamin D. If it is far above the lower level of the reference range, so I still have to give more vitamin D as compared to what I was giving during this period of test. Okay, so the first 6 months is like a testing period. We give a testing dose and we see how much the level of how much the level of PTH will decrease. So at the end of this 5 months periods, when we receive the patients in a second appointment, then I look at the level of PTH, and I have to calculate how much PTH, how much vitamin D, I have to give in addition to that previous dose, or how much vitamin D I have to decrease as compared to that previous dose. I don't know if I explain myself properly. So what we see here in this slide is an enzyme that is called CYP27B1, which is a kind of code for the enzyme that activates vitamin D, turning 25-hydroxy-D into 125-hydroxy-D, which is the active form of vitamin D. The gene that is used to express this enzyme may be changed, may be polymorphic in patients with autoimmune disorders like multiple sclerosis, like this publication is showing. So in order to understand how the resistance to vitamin D appears in this case, we have to look at the curve showing how the enzyme velocity changes according to substrate concentration. So as I increase the substrate concentration of a normal enzyme, the velocity increases. But at some point, it will reach the maximal velocity. So in order to characterize the activity of this enzyme, you have to calculate the half of this maximal velocity and the concentration of substrate that you have to achieve in order to reach this level of velocity. And this concentration is called Michaelis-Menten constant, or Km. If you have an enzyme that is whose gene is an enzyme that is expressed from a gene that is polymorphic, then the curve will be different. You will not reach the same level of maximal velocity. And in order to reach the same Km, you will have to, the same velocity, the same enzyme reaction velocity, you will have to achieve a higher concentration of substrate so that you have the same, you have to achieve a higher concentration of substrate to achieve the same velocity that you would achieve in the normal enzyme with a lower level of substrate concentration. That explains why we have to increase the level of substrate in patients with autoimmune disorder. Increase the substrate to that enzyme, which is 25. The substrate is 25-hydroxy-D. And if you have an enzyme that is has a polymorphic change gene that is causes even higher effect on enzyme activity, you will have to reach a much higher substrate concentration to achieve the same enzyme reaction velocity. This explains why we have to use high doses of vitamin D to achieve concentration of 25-hydroxy-D that is much larger than usual in order to keep the same reaction velocity. I think this explains, this is a good example to explain why we have to give high doses of vitamin D to patients with autoimmune disorders who have polymorphic genes. The same type of enzyme behavior is found when you study the interaction between the active form of vitamin D and the vitamin D receptor. Vitamin D receptor, or receptors of several receptors would behave like an enzyme and will have the same profile, so that when we have a decreased affinity of the receptor for its agonist, which is the active form of vitamin D, when the structure of this vitamin D receptor is changed, you need a higher concentration of substrate, which is the active form of vitamin D, in order to achieve the same biological effect. What do you think?
That sounds great. So just to clarify, because we talked about SNPs as well, so a polymorphism is the same as a SNP, right?
Yes.
Yeah.
SNP is a single nucleotide polymorphism.
And so individuals who have one or more SNPs, say they have one SNP, they might be that blue line in the middle. But if they have two, they might be that red line down below.
Yes,
so that's another way to describe vitamin D resistance, because these people with the polymorphisms are what we're terming as vitamin D resistant individuals, correct?
Correct. And important to say that vitamin D requires like 9 genes to function, but for his biological function. Okay, vitamin D requires 9 genes for his biological function, and you may have any combination of those of polymorphisms affecting those genes. You can have 1, 2, 3, or all of them combined, and each polymorphic change can be different, affecting one single gene. I mean that when you compare two people with the same autoimmune disease, those two people can have different combinations of 9 different polymorphic changes. And so it's impossible to calculate the level of resistance just by knowing the combination of polymorphic genes that this person has. And that's why we use the final effect, which is how much PTH has decreased when you give a testing dose of vitamin D for 5 months, and then you see how much the PTH has decreased, and then you can calculate how much vitamin D you can add to the initial dose, or how much vitamin D you can take away from the initial dose in order to match the level of resistance. So this is one of my first patients that I treated. She had SLE, and that was the result of only 10,000 units of vitamin D per day after 6 months of treatment. So you imagine how impressed I was, because that was the only change. The only change that I did in her treatment was to add vitamin D 10,000 units per day. So you see her right face here, the difference between before and after the treatment, the left face. So here you see another patient with psoriasis. You see the psoriasis lesions affecting this area of her face. And after 6 months taking 10,000 units of vitamin D, you see this benefit that she had. You see the difference giving her 10,000 units of vitamin D within, after 6 months, you see how improved the lesions were. So this is the same patient. So here you have patients with multiple sclerosis. She was born in 1982, and this is when she had the first flare of multiple sclerosis. So this was this MRI was taken in March 14, and you see those lesions. Those were recent lesions because it was her first flare. Okay, it's important to say that, because vitamin D has also effects on the cells that produce myelin, which is called oligodendrocytes. So it promotes remyelination in multiple sclerosis, but that remyelination only occurs when you have recent lesions. When you have lesions that are older than 1 year, back when you start the treatment, so it's more difficult to have a remyelination of lesions. But that provides a comparison between between March 2011 and July 2012. The two more than 1 year had elapsed between one MRI and another. Those lesions were active in the first set of MRIs. I'm not showing you this here, but they were taking up contrast. So you see here another patient who had a lesion, MS lesion affecting a critical area of the brain. This lesion can cause severe symptoms and disability. It was a patient born in 1989. The first slide was taken. The first slide is on MRI made in April 18, 2011, and the second slide was done about 2 years later, more than 2 years later. And you see the disappearance of that lesion. It was also a recent lesion. There were kind of lesions, old lesions here, who had not so old lesions, but you see that maybe the spinal cord is a little bit swollen because of some lesions were present here, but they also had disappeared 2.5 years later. So this is a severe type of multiple sclerosis. It's called Ballon concentric sclerosis. It's a severe disease related to multiple sclerosis. Usually patients do not survive for more than 2 or 3 years after the diagnosis. And you see the first MRI that was taken in October 2008, and there were several MRIs in between, but 5 years later, you only have the scar of those lesions and no additional lesion. So that was impressive to me. I was impressed with that case because as a neurologist, I know how Ballon's concentric sclerosis is a severe disease. So this slide is to show why we should not use the active form of vitamin D to treat those patients. So cholecalciferol, which is the form of vitamin D that we give to patients orally, goes to the liver, undergoes the first hydroxylation, turning it into 25-hydroxy-D. This increase in 25-hydroxy-D has no effect, does not inhibit the 25-hydroxylase located in the liver. So the 25-hydroxy-D goes to kidney and to immune cells like macrophages, and you will find 1-alpha-hydroxylase in both sites, in both cells. So they turned 1-alpha-hydroxylase they turn in the 25-hydroxy-D into the active form of vitamin D. The kidney releases into the circulation, the blood serum, but the immune cells like macrophages use this active form of vitamin D to supply its needs. It's not supposed to release in the circulation. So when 125-hydroxy-D is released in the circulation, it inhibits the 1-alpha-hydroxylase located in the kidneys. And this is an important step to prevent intoxication, because 125-hydroxy-D is capable of increasing calcium levels to a very high level. So we should avoid having that. And when we give cholecalciferol, you see that when the kidneys release 125-hydroxy-D, the 1,25-hydroxy-D released in the circulation inhibits the renal enzyme. So 1,25-hydroxy-D go to the intestines and bones, and it releases calcium in the circulation, and the release of calcium in the circulation further inhibits the 1-alpha hydroxylase located in the kidneys. But this has no, calcium level has no effect in the 1-alpha hydroxylase located in the immune cells. So that's the reason why we should use cholecalciferol and never use 1,25-hydroxy-D. Because if you use 1,25-hydroxy-D, you will bypass all this controlling homeostatic mechanisms. And this does not happen when you use cholecalciferol. So this is something important. It shows how 1-alpha hydroxylase works, both in the kidneys and in immune cells, and in several other tissues, like the brain, placenta, and several other tissues. So the reduced form of 1-alpha hydroxylase is capable of synthesizing 1,25-hydroxy-D, but it requires magnesium as a cofactor. But when it turns 25-hydroxy-D into 1,25-hydroxy-D, it gets oxidized. So in the oxidized form, 1-alpha hydroxylase cannot pick up another molecule of 25-hydroxy-D to turn it into the active form of vitamin D. So it has to go back to the reduced form. This enzyme belongs to the cytochrome P450 superfamily, comprising like more than 100 enzymes. And this family of enzymes have an auxiliary enzyme that is called reductase of the cytochrome P450. And this enzyme requires both the active forms of vitamin B2 as a prostatic group, and it's capable of reducing the oxidized 1-alpha hydroxylase. When this occurs, the reductase is oxidized, but it is capable of reducing itself back to the reduced form of cytochrome P450 reductase. So this cycle has to go on. In order for this cycle to go on, you need this cycle to go on. So in order to keep hydroxylating vitamin D to the active form, you need magnesium and vitamin B2. And it's important to know that like 10 to 15% of the world population has reduced ability to absorb riboflavin. Several of those people have autoimmune disorders. This was demonstrated by this article published in 1994. So this is extremely important to me because it's like 10% of the world population. It's important to say that high doses of cholecalciferol should be taken under the supervision of an experienced physician to avoid harming renal function.
Real quickly, Dr. Coimbra, can you just define what high dose is? Because some people consider high dose the 10,000 IU a day. Is that the dose that you're talking about, or are you talking about the doses that you use in your protocol, the 1,000 IU per kilogram, correct?
Yes. Okay. 10,000 units per day is an amount of vitamin D that you can produce by solar exposure. So nobody has ever nobody has ever got intoxicated with vitamin D by exposing the skin to sunlight. So if you are lying down on horizontal position, you have a fair skin, and the sun is high enough, you have your skin is a young skin, then you can produce this amount of vitamin D within like 20 minutes or 30 minutes. So it's hard to believe that people still believe that 10,000 units of vitamin D is a high dose of vitamin D, considering that this is easily produced by exposing the skin to sunlight. So when I'm talking about high doses of vitamin D, I'm talking about the doses that we give to patients initially, which is 1,000 units of vitamin D per kilogram per day. So this is a high dose. So
And maybe it could be called a therapeutic dose because it's what you're using to help treat these patients and not necessarily what somebody in the general population might take just to maintain their vitamin D levels.
never, the general population should not take this high dose of vitamin D. Only patients who have autoimmune disorders and under medical supervision.
Mm-hmm. But I'm glad we clarified that because the therapeutic use is the use that should be used with a medical provider who is observing and watching for toxicity and measuring the PTH and all of that. I just wanted to make that clear. So I'm going to let you go ahead and keep moving forward.
Okay. When we give high doses of vitamin D, I was talking about the initial dose of 1,000 units of vitamin D per kilogram per day. This is usually our testing dose for diseases like, say, rheumatoid arthritis, to see how much the PTH will decrease when we increase the dose of vitamin D. But if I am treating a disease like psoriasis, I don't have to start giving that amount of vitamin D. I can give like say for a patient who weighs like 50 kilograms, I can give like 30,000 or 40,000 units per day as a testing dose because it's not an emergency. Okay. But that changes when I have an emergency. For instance, if I have a patient with multiple sclerosis who is at risk of losing his vision because of optic neuritis, or just had an episode of optic neuritis like 2 weeks ago, and is coming for the first appointment. So this is, to me, this is an emergency because I know that if I give high doses and I immediately increase the dose of vitamin D, the level of vitamin D to a high level, I know that I can reverse the visual loss that this patient has. So in this case, I would give to this patient a loading dose of vitamin D. And what I'm going to tell you has been published. If I don't, probably it was published by a group of Italian researchers in 2018. They showed if you give 600,000 units of vitamin D as a single dose orally, on day 3, the patient will have a level of vitamin D which is around 18 nanograms per ml. And that it means that I will normalize the level of vitamin D immediately by giving this loading dose. So, but I will not give this loading dose to a patient that comes for the first appointment and has only only psoriasis. There's no emergency in that situation. I can check the level of resistance to that patient 6 months later and adjust the dose. There's no rush in increasing the dose of vitamin D immediately. But in a patient in that situation who had a flare of multiple sclerosis affecting his optic nerve, then I may give him this loading dose. I will definitely give him this loading dose because I don't want to miss the therapeutic window to reverse his this visual disabilities. I need high level of vitamin D to be achieved immediately so that I can get the effects of vitamin D in terms of remyelination of the optic nerve. Is that clear enough? So the initial dose may vary according to the patient's condition and to his to the type of disease that he is having. Okay. Okay. So, but we can have intoxication of vitamin D because using high doses of vitamin D because patients should follow a strict diet. They should not have dairy products in their diet and other diet items that are high have high level of calcium. So they have to follow this strict calcium diet. And sometimes they just they are doing so well that they just don't feel that this is important, and they don't follow the diet as strictly as they were recommended to. So one of the causes of intoxication is an unreliable source of vitamin D. Another cause of intoxication is urinary tract infections, particularly pyelonephritis. For some reason, when you have a urinary tract infection, even if you are not taking vitamin D, any supplement of vitamin D, your calcium level may increase. There a mechanism by which urinary tract infection decreases the urinary elimination of calcium. So it's an important part of the protocol is to prevent urinary tract infections. And because the urinary tract infections are caused by microorganisms that are present in our feces, it's extremely important and extremely effective to wash the perianal area after having a bowel movement, so that you remove all microorganisms from that area. Sometimes we may, for some patients who have recurrent urinary tract infections, after washing that area, they have to apply a topic antibiotic after washing that area. So poor compliance with dietary calcium restriction is another possible cause of intoxication. Hyperthyroidism, uncontrolled hyperthyroidism, like in Basedow-Graves disease or nodules in the thyroid gland that produce high amounts of thyroid hormones. This condition can, when it's associated with high doses of vitamin D, can lead to intoxication. And this is because thyroid hormones, just like vitamin D, they may remove calcium from our bones, and the patient get intoxicated, not because of the calcium in their diets, but because of large amounts of calcium that are released in their bones in that condition. So if we have a patient with Graves' disease, first we have to control the Graves' disease by using proper medications that decrease the release of thyroid hormones from the thyroid gland. So it's extremely important to have hyperthyroidism under control before starting this treatment. Basdo Graves is autoimmune disorder and responds to high doses of vitamin D, but we cannot start high doses of vitamin D without controlling the release of large amounts of thyroid hormones from the thyroid gland. So we found this is for experiences that when patients are taking very high doses of vitamin C, they may get intoxicated. And high doses of vitamin D, very high doses of vitamin C, produce a kind of a situation called systemic oxalosis. So we advise patients under this treatment to avoid supplements of vitamin C higher than 250 milligrams per day. So we also found that lithium, this drug that is used in psychiatry, lithium can induce hyperparathyroidism. So it can increase the release of PTH in parathyroid hormones, and this can cause intoxication. So if you are at the same time using a high dose of vitamin D and you have a high level of PTH because you have you are taking lithium, and lithium increases the release of PTH by parathyroid hormones. So the use of lithium can cause intoxication when we are using this protocol.
Real quick about vitamin C. Is it only vitamin C from supplements, or do you also have to worry about vitamin C from foods?
Only from supplements.
Okay.
Patients can take as much vitamin C as they want by taking fruits and other foods like that. So we also found that aromatase inhibitors can increase calcium levels, but at this point I don't know the mechanism related to that. But we found that when some patients started using those aromatase inhibitors for prevention of breast cancer, some of those patients got intoxicated with vitamin D. I mean, their calcium levels increased above the normal range. So we have I don't know if you would like to go through those steps, but we have a protocol when intoxication happens. We have a protocol to use in order to induce a recovery from intoxication. Maybe it's not interesting to go into those steps.
Let's go through it, because we might have some practitioners who are interested in learning more and maybe even reaching out to you for training.
Patients who are under this treatment should be aware of symptoms of increased calcium levels, such as persistent nausea and constipation. When that happens, they should stop taking not only nausea, isolated nausea, or isolated constipation, but when the two symptoms are associated, then they should be concerned about the possibility of having high levels of calcium, circulating calcium. So the first measure is to stop taking vitamin D and all other supplements that we give to those patients except for magnesium. This is important because magnesium is a natural calcium blocker, and it's important to keep the the intake of magnesium supplements, and sometimes even to increase that dose. So they have to increase the daily hydration for 1 more liter, because usually when the patient starts on that treatment, we ask them to take at least 2.5 liters of liquids in general per day. But in that situation, when those two symptoms are associated, then we ask them to increase their daily hydration to at least 3.5 liters per day. So we doubled the daily amount of magnesium that we use in this protocol. We usually use 100 milligrams of elemental magnesium 3 or 4 times per day, and we have to double that amount. As another step, we start using furosemide, which is diuretic drug, 40 milligrams, 1 tablet twice a day for 1 week, and then reduced to once a week. We start supplementation of potassium to avoid the side effect of furosemide, 100 milligrams, 1 tablet twice a day for 1 week, and then reduced to once a week. We also give them alendronate, biphosphonate, because biphosphonate immediately blocks the release of calcium from the patient's bones. And it's important to say that patients usually get intoxicated because of the calcium, the large amount of calcium that they are releasing from their bone tissue, and not because of the diet. Usually it's not because of the diet, because you are usually following the diet. So giving a biphosphonate is a way to stop the intoxication immediately, because you stop the releasing of calcium from the bones. So we ask patients to collect blood and urine samples once a week as prescribed, and they are sending those results to us as soon as the results are available. This is different as compared to what happens in US, because who receives the laboratory results in US seems to be the doctor. In Brazil, patients and doctors have access to laboratory results. That's in summary, that's what we do when we have a case of intoxication, and all doctors that have been trained in our clinic are taught to use this protocol as part of their training. So those are the lab tests that we use whenever we have a case of intoxication. We order parathormone. Obviously, if the parathormone is above the lower limit of the normal range, the patient is not intoxicated, because when calcium increases above its upper level of normal range, when calcium is increased, it inhibits the release of parathormone by parathyroid glands. So total and ionized calcium are one of the those four items are blood tests and urinary tests that we always order in order to treat intoxications. TSH is also included here because, of course, we want to know if the cause of intoxication is hyperparathyroidism that may begin at some point. So we also order urinary culture of urine to assess sensitivity of antibiotics, and we start antibiotics as soon as we receive positive urine test, urine culture. So this is related to your question.
Can you answer the question for me? Is vitamin D toxicity once the patient has shown symptoms, are all of those effects completely reversible? Or is there any permanent damage from the vitamin D toxicity that these patients experience?
If we start the treatment of to reduce to stop intoxication immediately, then everything is reversed. All damage to kidneys is maybe reversed. If we take a long time to start that detoxification protocol, then it might the patient may have some damage to his renal function. But that's why we are deeply concerned about having the patients are aware that they should let us know as soon as they are having those symptoms. And we gave them laboratory prescriptions, laboratory orders so that they have laboratory orders to immediately collect blood samples as soon as those symptoms started.
Okay.
So this is something that we always give patients laboratory orders without a date so that they can use it whenever they want, as soon as it's necessary. Even before they contact us, they may start measuring calcium levels in their urine, because the urinary calcium level is the first to increase. So if the urinary calcium is within the normal range, then it's unlikely that this patient is intoxicated with the vitamin D.
And you also mentioned that the calcium usually comes from the bones. Do you ever see any effect on the bone health with this protocol?
Yes, and this is an important question. When we when we give a dose of vitamin D, like 10,000 units of vitamin D, you may expect to have to increase the absorption of calcium to your bones. When you increase the dose of vitamin D to more than 20,000 units per day, then the effect on bones is both increasing the absorption of calcium, the stimulation of osteoblasts, and also the increase in on the release of calcium from the bones due to the stimulation of osteoclasts. So at some point, you have both a stimulation of osteoclasts and a stimulation of osteoblasts. And if you increase the dose of vitamin D further, like more than 40,000 units of vitamin D, you will increase, you will stimulate osteoclasts more than you will stimulate osteoblasts. So the release of calcium will be increased in those patients. And in order to prevent that, the best measure to prevent that is to do physical exercise. Because if you have strong muscles, you have strong bones. You cannot have weak bones if you have strong muscles. This is the way that nature works. If you submit your bones to forces during physical exercise, like musculation, to increase the muscle mass, you will also increase the calcium level, calcium concentration in your bones. So it's extremely important. It's part of our protocol. Patients cannot remain at home just taking that's taking high doses of vitamin D, they have to do physical exercises. And I ask them to do physical exercises every day, especially those exercises that are related to muscle hips. They are simulated to do that every single day, maybe twice a day, if possible, twice a day. And this is extremely effective to prevent the loss of calcium from the bone tissue. Is that what was you were asking?
Yes.
An additional information.
Okay.
Is some patients cannot do physical exercise because they are in a wheelchair for several years. They are in a situation of irreversible damage to their spinal cord, even years before they started this treatment. So I cannot ask them to do physical exercise. So in that case, I have to use medications that stop the release of calcium from their bones at the same time when I started giving them a higher level of vitamin D. And it's something extremely important regarding that question. Is this when we started paying attention to the mental health of our patients, meaning when we started asking them to control their emotions by controlling their thoughts, because you are under stress because of the thoughts that you are accepting in your mind because of the problems that you are facing. But if you learn techniques on how to control your thoughts as a way to control your stress, I can see that those patients do not require those high levels of vitamin D. And I see in the laboratory tests that I have to decrease the level of vitamin D, the doses of vitamin D, because they seem to be no longer so resistant to vitamin D as they were before. And that's why the control of emotions has become the basic of this therapy.
Mm-hmm.
I don't want to keep patients on high doses of vitamin D forever. I want to decrease their daily doses of vitamin D, and I can decrease their daily doses of vitamin D if they decrease the level of stress. So this is part of the treatment. I have several patients that are no longer taking high doses of vitamin D because they learned how to control their emotions. So techniques like mindfulness are very important to those patients, and we ask them to look for informations like that. And I don't know if I could transmit how important this is for this protocol. It's not about giving them only about giving high doses of vitamin D to match the level of resistance. This can be the first step. But as time goes by, the patient is now aware that he is no longer having those symptoms that he had before. And one of the most important symptoms is fatigue at rest. Fatigue at rest almost disappeared after 1 month of treatment. And this is a way of measuring the strength of a systemic inflammatory condition. A systemic inflammatory conditions cause fatigue at rest. So if this is decreased after one month of treatment, I know that the inflammatory process is becoming under control. And that's a question that I consistently ask to all patients. What's your level of fatigue in a scale from 0 to 10? Because when they come back, I will ask that question again. Another question that I ask patient is something like this. Suppose there is a scale, an imaginary scale of stress that goes from 0 to 10. 0 does not exist, would be someone that does not get stressed for anything. So that does not exist. But level 5 would be the average level of stress that a person of the an average person of the population has, and a person that is facing common problems, regular problems, ordinary problems. And level 10 is the maximum level of stress that a patient may have, that someone may experience. So I ask the patients, what's your level of stress? And it's unbelievable. There is no patients that were happy, calm and happy when they got sick. It's unbelievable.
Yeah.
And when they got sick, they were facing a stressful life event that was much higher than the stressful life events that they used to face in their lives. So when they have the first appointment, this is another question that I ask right now: what is your level of stress in that scale from 0 to 10? Because when they come back, I'll ask them again to see if they could decrease the level of stress. And if they could not decrease the level of stress, I will reinforce the importance of this in order to live a normal life without having to take high doses of vitamin D.
Mm-hmm. This is a really good point and important to know about the Coimbra Protocol, that it's not just about giving very high therapeutic doses of vitamin D. It's adjusting lifestyle in terms of exercise, emotional health, and diet. And all of those. Wow. So you can actually get them off of the therapeutic vitamin D if they can control their stress. That's pretty phenomenal.
Yes, they can. But sometimes there are patients that are unable to control their stress, no matter how much you talk about. But we are always trying in every appointments. And I would say that most patients are now realizing how important this is for the success of the treatment.
Mm-hmm. Do you utilize any other nutrients or interventions to specifically address stress for those individuals who have a hard time just controlling their mind and
Magnesium
behavior?
itself has this effect.
What was it?
Magnesium itself has this effect. So the dose of magnesium is adjusted according to the maximal dose that the patient can take without having diarrhea. So it's important to say that some magnesium salts are not suitable for any treatment like that. For instance, magnesium oxide causes a lot of diarrhea, should never be used as a magnesium supplement for those reasons. Because most of the magnesium oxide are not absorbed. They remain in the bowels, within the bowels. And high concentrations of magnesium in the bowels cause diarrhea. So we use other types of magnesium compounds, like magnesium glycine, magnesium glycine, magnesium threonate.
You ever use citrate or
No, I don't use citrate because
malate?
citrate increases the absorption of aluminum in our food. So aluminum is a terrible metal. So I don't use citrate. So citrate is avoided, and and magnesium oxide is avoided, should be avoided. And we adjust the dose, as I told you, we adjust the dose according to the bowel movements. The patient should be having bowel movements every day, at least once a day, but without diarrhea. If they are not having bowel movements every day, they should increase the dose of magnesium. If they have diarrhea, they should decrease the dose of magnesium. So magnesium is giving us within some multivitamin supplement that I give the patients, but just the basic daily dose of magnesium, which should be around 100 milligrams of magnesium 3 to 4 times per day within that polyvitamin compound. But I give an additional magnesium to adjust the dose according to the bowel movements. So literature related to magnesium supplementation says that you have to adjust the dose according to bowel movements. Okay? So I think that this is really important to say. But some other supplements can cause can reduce stress. One of the supplements that can reduce stress is glycine. Glycine is amino acid, and it can reduce stress. So we used to use magnesium glycine as a preferential form of magnesium. But if I want to have more effects in the central nervous system, I might use magnesium threonate. If I want to increase the release of if I want to detoxify aluminum today is a major concern of ours in this protocol, because we are seeing a lot of patients with problems related to aluminum. But we can get back to this subject in a while if you want.
Yes, I would like that. Yeah.
Okay.
Well, would you like to continue? I had a few other questions about other co-nutrients, but I don't know if you're already planning on getting there. For example, you talked about the B2. You've also mentioned omega-3s, and then a lot of people ask about vitamin K. And there's questions about vitamin A. So if you want to save those for later.
No, I can answer now.
Okay.
By one. The first one would be?
Well, let me rewind a little bit and ask you, because I think there's a misconception that taking very high doses or just high doses, not even therapeutic doses of vitamin D, can induce deficiency of another nutrient. But the way that I like to refer to it, or several of our other scientists have referred to it, is that correcting vitamin D deficiency and taking, that 10,000 IU of vitamin D a day as the high dose simply reveals inadequacies of other related nutrients. So it's not necessarily causing another nutrient such as magnesium or any of the B vitamins to become deficient. It's just showing that they're already the intake is already too low to support normal function. Would you agree with that? Or are there any specific nutrients that you also concern yourself with when you're putting your patients on higher vitamin D?
Well, I try to increase the capacity of fighting inflammation in my patients. So omega-3 that you have mentioned is part of our protocol. So we give them omega-3, high concentrated omega-3, 3 times per day as part of our protocol. So they will produce their own anti-inflammatory substances. Regarding vitamin K2, we several years ago, I would say like 15 years ago, we tried to give vitamin K2 as MK7. to try to prevent the loss of calcium in the bones of patients with under high doses of vitamin D under our protocol. But it was useless. This did not work. So it only made the protocol more expensive. So I gave up using vitamin K2.
And you didn't see any buildup of calcium in the arteries or any other tissues that it wasn't supposed to be?
If you keep the calcium level, circulating calcium level, within the normal range, there is no reason to be concerned about calcification of tissues. Tissues may calcificate if you have high levels of calcium in your circulation. So I keep the level of calcium within the normal range by using the diet and other measures. But I don't use vitamin K2. It sounded, I understood that it was useless. It did not change anything. Laboratory tests, bone mass were not changed. So what else would you like to ask regarding that, those additional supplements?
Do you put all of your patients on B2 and other B vitamins? And for how long?
Well, as I showed you, like 10% of the world population cannot absorb vitamin B2 completely, cannot absorb properly. So I keep this a high dose of riboflavin, which could be something between 50 milligrams to 100 milligrams, 3 or 4 times per day, to make sure that all those patients who have problems related to their absorption of vitamin B2 will have the benefit of receiving vitamin B2 in a larger doses that would overcome their poor absorption, intestinal absorption of vitamin B2. So it's so important for that reason that I showed you in another slide. Vitamin B2, the 2 forms of vitamin B2 is required for that auxiliary enzyme that is necessary for the function of the vitamin D hydroxylases. So this is something important. Magnesium and vitamin B2 should be given to all our patients, at least those 2 additional supplements. But we also give omega-3, high concentration omega-3. I also give that's important. I also give them methylfolate and vitamin B12. Okay, because lots of those patients have abnormalities related to folate cycle, and folate cycle is important for such a large amount of functions, biochemical reactions in our organism, including the production of a glutathione. So we depend on a good folate cycle to produce glutathione, which is the main antioxidant mechanism in our organism, the main antioxidant defense in our organism. So I try to provide vitamin B12 and methylfolate. Never use folic acid. Folic acid should never be used. Should never be administered to any patient, because like 30% of the whole population will have problems related to the administration of folic acid. Folic acid is not the normal vitamin B9 that is available in nature. It's produced by pharmaceutical companies as a folate that is resistant to heat, but it should not be given to the whole population. No, and because like 30% of the whole population, the whole world population, they had problems related to SNPs related to folate metabolism. I always give them methylfolate. Always give.
So it sounds like you are you
Those
individualize treatment to your patient's specific needs. You adjust the co-nutrients according to your patient's individual needs.
Yes, I do.
Mhm.
But your question is very important. I'm always concerned to keep myself in a good state of folate metabolism, which is demonstrated by homocysteine levels. And it's a major factor related to the elimination, detoxification of metals like aluminum.
Mhm.
Aluminum is a major, perhaps the major health problem worldwide. I'm not exaggerating. What I'm seeing is impressive.
Yeah, and we'll talk more about that a little bit later, especially as it relates to autism. So you only measure the homocysteine to get an idea of the B vitamin SNPs, or do you ever do any genetic testing?
I measure homocysteine, especially in people who are older than 40 years old. But since I started treating pediatric patients with autism, ASD, I was impressed to see that some of them have high levels of homocysteine.
And the
And
high homocysteine is related to which B vitamins? Is it just the folate, or is it also B12? Or explain a
mainly
little bit.
maybe related to B12 and B9. B9 is the methylfolate.
Mhm.
But you see, vitamin B2 also plays a role in those folate cycles. And magnesium also plays a role. So giving magnesium and giving vitamin B2 is giving vitamin B12 and vitamin B9 in the form of methylfolate are important items of our protocol.
Okay. Just a couple more questions on this topic, because the microbiome is an important piece in our overall health as well, especially when we're talking about autism. Do you ever address the microbiome as part of your protocols? And I believe if you've got a healthy microbiome, your gut can actually produce a lot of these B vitamins.
I'm especially concerned about that when I treat patients with ASD.
Mhm.
But in all patients, I advise them to have a healthy diet that will, because if your food is related to the type of microorganisms that you have in your bowels, right? In your
Mhm.
intestines. So I suggest them to decrease as much as possible the amount of meat that they are eating, um, and change the source of proteins to vegetable sources of proteins and eggs. If this is not sufficient, then try to use fish other than other type of meat. Um, and sometimes, yes, I do supplement those patients with probiotics. It's a major concern of ours.
Yeah, right. One more question about other nutrients, because there are certain groups that believe taking high doses of vitamin D can deplete your vitamin A. Do you ever concern yourself with vitamin A?
as you are asking questions, I'm reviewing what I'm doing. And yes, I told you there is
Spoiler alert.
yes. You remember that I told you that I give patients a compound of vitamins, and vitamin A is included to that because in order to vitamin D uh, has its actions at the level of vitamin D receptor within the nucleus, vitamin A will be required. So this is also added to a supplement of vitamin A, like 500 micrograms 3 times per day is part of our protocol nowadays. Maybe several years ago it was not, but now it is.
Okay, and we're talking retinol, right? Not the beta carotene, the precursors.
Sorry?
We're talking the preformed vitamin A, correct?
Yes,
Yes.
right,
Okay.
right.
All right. So just to kind of wrap this little part up, when we're talking, quote, high doses of vitamin D is in no more than 10,000 IU a day. Do we need to concern ourselves if, for example, if I take 5,000 IU of vitamin D a day? Do I have to concern myself with these other nutrients if I don't have any symptoms that reveal a current inadequacy? Will taking that amount deplete or cause a deficiency of any of these other nutrients that we've just talked about?
By giving vitamin D,
Yeah, 5,000, 10,000 at most a day.
this is,
Okay.
you produce that amount by exposing your skin to sunlight.
Well, orally, though, it's a little bit different. Our body's got built-in
Yeah.
mechanisms with how much vitamin D we produce, and it's produced over a longer period of time. But I just want to address this because there are certain people who are afraid to take oral vitamin D because they've heard that it can create other deficiencies.
I have been using high doses of vitamin D uh, for more than 20 years now, and I did not have that kind of problems in any patients, and you can count to thousands and thousands of patients that I have seen during these years. So I'm really not concerned about this. What I told you, those supplements that I told you about are those that we use. And that's it.
Thank you. All right, well, I'll let you carry on with your presentation. Thank you so much.
Welcome. Okay, this slide shows that vitamin D, when you give doses like 1,000 units of vitamin D per day, your level of vitamin D will essentially will not change throughout, say, 3, 4, or 5 months. It will not change significantly. This graphic shows that even a daily dose of 1,000 units will not significantly change the circulating levels of vitamin D after several months of supplementation. Taking 1,000 units of vitamin D may be regarded as a high dose, just because the IOM, the Institute of Medicine, recommends only 600 units per day. And this is nothing. 600 units per day is nothing. The graphic also shows that when you give 10,000 units of vitamin D per day, which is no adverse effect level, you will reach 800 nanograms per ml, which is equivalent to 200 nanomoles per liter. And this is completely normal. You can't have, if you are not resistant to vitamin D, you will not have the full effect of vitamin D with levels below 60 nanograms per ml or 150 nanomoles per liter. People who with low levels, with low body weight, may achieve levels significantly higher than that, by higher than 80 nanograms per ml by taking 10,000 units of vitamin D per day. But it's still no IL. It's still no adverse effect level. Vitamin D is a fat-soluble steroid, and fat tissues act as a sponge, a kind of sponge, so absorbing vitamin D from the circulation. Therefore, in a person with increased fat tissue, the daily requirement of vitamin D needed to achieve its biological effects also has to be increased. Some people with obesity may have to take like 20 or 25,000 units of vitamin D per day to achieve this level of 80 nanograms per ml. As I told you, in case of an emergency, like during an epidemic or the pandemic that we experienced a few years ago, an initial dose of 600,000 units of vitamin D should be given orally. And depending on the body weight of that person, it could be repeated in the next day to achieve the desirable level of 18 nanograms per ml immediately, because it's an emergency. Well, I already told you that I also considered an emergency patient with MS who is at risk of blindness, and then because of optic neurites. We also treat patients with other autoimmune disorders that may lead to blindness, like uveitis, for instance. We also give high doses of vitamin D to those patients, and I might give a loading dose like that to those patients. So this is a way of classifying patients or classifying their situation as an emergency or not. So if it's an emergency, we have to use high doses of vitamin D. So, but I would like to emphasize this: 1,000 units of vitamin D per day, only a minor change in the level of vitamin D as compared to someone who takes 0 units per day. And the IOM advises 600 units per day. So we see that this is an absurd, and I don't understand how this advice has remained for so many years, in spite of those publications like that, repeated publications. So the importance of vitamin D in pregnancy. I saw that this was one of your questions, and it's one of my main concern also. Vitamin D has numerous effects in pregnancy. It's sufficient to say, as a preliminary information, that vitamin D is activated in the placenta, both in the maternal side of placenta and in the fetal side of placenta. It is the placenta expresses that 1-alpha hydroxylase enzyme that turns vitamin D into 25-hydroxy-D into the active form 1,25-hydroxy-D. And this has antimicrobial, microbial, and anti-inflammatory effects. It will prevent a miscarriage due to autoimmune aggression against the fetal tissues. So the same article that I was mentioning here by Liu and Hilson also showed all those situations that you may have if you have low levels of vitamin D during pregnancy. And I would emphasize the maternal fetal HIV transfer, autism, multiple sclerosis later on, in this individual life. The risk of diabetes in childhood, if the mother had low levels of vitamin D during pregnancy, and asthma. And all those complications in pregnancy you may have if you have low levels of vitamin D during pregnancy. So you can imagine how much problems you may, the amazing number of problems that you can prevent by just giving a pregnant woman an amount of 7,000 units of vitamin D per day, which is completely safe. It's important to say that some of our patients, MS patients, for instance, who were unable to get pregnant, when they started receiving high doses of vitamin D, they got pregnant within a few months. So, and you have vitamin D and fertility. You have more than 70,000 papers published related to that. As a neurologist, I'm really concerned about fetal brain development. And I see that patients who are having 7,000 to 10,000 units, or even high doses of vitamin D, as we use in our protocol, the neurodevelopment of those children are amazing. It's amazing, amazing. They are not only have a high IQ, they are happy children. It's amazing. They are completely different children. So I'm always wondering what will happen with humankind when the advice of giving 10,000 or at least 7,000 units of vitamin D during pregnancy. What will happen with humanity? Because we'll have a completely different kind of human beings, as I have seen during this 20 years when I started using this protocol. But I have to say that this benefit may be lost during due to administration of vaccines containing aluminum nanoparticles in pregnancy, and a large amount, increasingly amounts of vaccines that we are giving to children.
Okay, so I've been in touch with Dr. Renu Matani, who was also trained with you, and I know she's training in India, and I'm not sure about training in other parts of the world, but would you encourage others to seek her and others who are possibly also training the other doctors in the Coimbra Protocol to reach out to them?
Yes, definitely. Dr. Renu Matani is a very clever and efficient lady. She is doing a wonderful work training other doctors, and I definitely need other doctors to train doctors, so that I'm the only one to be trained. I'm the only one. I don't want to be the only one person training doctors in this so-called Coimbra Protocol,
Mm-hmm.
as it's now known by patients.
And
Definitely, I would encourage her to continue. She's been in touch with me because of that, and I have already encouraged her to go on with that activity.
so she's got your full support. That's good to know. One concern that she brought up, and I'm curious if this is also a concern for you in Brazil, is that some doctors, some practitioners who are doing the high dose, the therapeutic dose vitamin D, there's some concern on their end for legal or lawsuits legal actions taken for patients who do reach that toxicity. Has that ever been a concern for you? Have you had to deal with that in your practice? Or what is something that you could tell doctors who are, or do you already tell practitioners who are doing this to?
Well, you understand that we are facing opposition from the medical community.
Mhm.
And it's been like that since we started with this protocol. But I have to deal with this. This is something that it's part of my routine now. And what can I say? For instance, if you go to the Scholar Google and you type migraine and you type riboflavin, you will see that there are thousands of publications showing that high doses of riboflavin, like 400 milligrams per day, control migraine in 80% of cases. And if you add magnesium to that treatment, you will reach close to 100% of cases under control. And you see that there is placebo control groups, studies using placebo control groups, randomized placebo control groups, everything that is suggested or indicated by the so-called evidence-based medicine. But there is not a single word about riboflavin in the textbook of the medical doctor that treats migraine. So it's my opinion that the transmission of knowledge within the medical community is under strict control. And it seems to me that any kind of new therapy that is addressing the cause of diseases and carries the possibility of decreasing the commercialization, the trade of medicines. They seem to be excluded from textbooks and medical meetings, so that it doesn't matter if you have thousands, tens of thousands, or hundreds of thousands of publications, they are not mentioned. So I don't have anything to do about that. I just have to keep my work, to do the best I can for my patients. And when there is some litigations, I have to try to deal with that as in the best way I can. But I cannot be stressed because of that, because I know that stress triggers diseases. So it really has to be part of the routine. Even Dr. Martani has received criticisms from her peers. So I think that this is expected. It's not something that you should be surprised to see about that. Maybe in some countries like the US, the pressure on medical doctors may be higher than in other countries, for obvious reasons. Most pharmaceutical companies are located there. But it's a problem that we have to face.
Mhm. Because I bet you've probably seen the amount of effectiveness that comes from the use of therapeutic doses of vitamin D, how effective it is. And I'm assuming, correct me if I'm wrong, that it's probably safer than a lot of the pharmaceutical drugs on the market for some of these diseases that you're treating with vitamin D.
I'm sure about that.
Yeah.
The medicines that are sold to treat autoimmune disorders are very expensive, very, very expensive. There is one medication for MS that 5 tablets cost like $46,000 in US. So you can imagine what is happening what would happen when someone tries to provide another treatment that instead of causing depression of the immune system, enhances the power of immune system in fighting infections. And there is something else that I have to add, some other information. Most of when they say that in order to be accepted by the medical community, you have to perform a placebo-controlled, randomized placebo-controlled study, multicentric. We don't have money to make a multicentric study. I would never ask some relative of mine to take part of a study like that, using just to prove that vitamin D given in high doses controls those autoimmune disorders, because I know that those patients who fall in the control group will be damaged and will be damaged forever. So I don't feel comfortable about that. I would never do that. And another issue is that this type of study is impossible. It's not. It would not be blinded, double-blinded, because you have to adjust the dose according to the resistance of the patient. So you have to see the laboratory results and adjust the dose according to those laboratory results. So that's not possible in terms of placebo-controlled studies, double-blind placebo-controlled studies.
Right.
So that's it. We have to go on and do as much benefit to our patients as possible.
Yeah. Yeah. And in the meantime, those who do take this into practice can rely on other doctors like you, Dr. Matani, and the many very knowledgeable vitamin D researchers, such as those on the Grassroots Health panel. We've got a great community of individuals who are well aware of what's going on. Dr. William Grant, for example, wrote the vitamin D misinformation playbook, and he talks about this a lot. And you just can't let that scare you. And just have faith that this really does work. Yes.
Some other doctors that were trained in our clinic also have published about the safety of the Coimbra Protocol, and they have other doctors like those were, I guess it was from Germany. They produced 2 papers, and there is another paper published by Italian groups of medical doctors showing the improvement of quality of life. Mm-hmm. Those patients having under high doses of vitamin D. So
I know.
I'm glad to see that other doctors are planning to publish that, because I cannot do everything on my own. I need cooperation.
That brings me to a question that one of our doctors sent me, and I hope you don't mind my asking you now. But Dr. Patrick Nicolo has published several papers. He is a medical doctor. He's been using high doses of vitamin D with all of his patients in the hospital that he works at. And he was wondering if you would be willing to collaborate with him on treating patients with Parkinson's disease. That is one of the things that he would like to speak with you about, the therapeutic doses of vitamin D on Parkinson's, and then publishing.
Okay, I'm glad that you asked that question. I'm open to cooperate with any doctor, any physician, but I have to say that Parkinson's disease is not an autoimmune disorder, and we don't use this high-dose vitamin D protocol in Parkinson's disease.
Okay.
Parkinson's disease is one of the most cases of diseases that we see very, very high level of stress in those patients. They have ever been extremely worried about all problems that they face. They are highly responsible people. They don't accept, or don't want to accept that things are not under possible bad outcome. The outcomes of the problems that they are facing escape their control. They are trying to control everything. They are afraid of things that may happen. They think about every possible outcome of any problem they are facing. This is essentially the personality that is seen in almost 100% of patients with Parkinson's disease. And we have been dealing with Parkinson's disease by trying to change that personality. Of course, we give vitamin D, not in high doses, what I call high doses. I'm not sure what you're calling high doses in your question, but I'm giving like a 10, 15,000 units of vitamin D to patients with Parkinson's disease. Because several years ago, I tried to give them high doses of vitamin D, and I felt it did not work. So we are trying other measures to decrease the activity of that disease, like giving glycine in high doses of glycine, which is an amino acid that decreases, that causes calmness, induces calmness. We are associating that with N-acetylcysteine. Also, it seems to be working in the first few patients. I hope that impression goes on. But Parkinson's disease is not an autoimmune disorder. And I guess that this confusion came from the fact that doctors that were here to be trained on high doses of vitamin D, because I'm a neurologist, I was also seeing patients with Parkinson's, lots of patients with Parkinson's. And maybe there isn't this impression that Parkinson's disease is respond to high doses of vitamin D. That's not my impression. But we correct the level of vitamin D in those patients too, because of the effects of vitamin D has in the central nervous system, in the brain, inducing neurotrophic factors that increase the lifespan of neurons. So that's what I have to say about that. No other information I have available.
For the practitioners who are interested in going through the training for the Coimbra Protocol, I really wanted you to share a little bit more about what's involved with that. I know I sent some questions from our own scientist panel and some of the other doctors in our network, but I would like to just kind of turn the conversation from that for the general public to those who are in the medical field who might want to come and learn more from you.
So you are asking about training of other doctors? Is that what you mean?
Yeah, I sent some questions for about the training and the protocol, such as what is the cost of participation and what is the curriculum? How many hours does it take? If you could just kind of share a little bit about what is expected for those who want to be trained, because we don't have enough Coimbra protocol practitioners in the United States. So if
You
there,
You have 5 of them. I trained 5 medical doctors. I think that 4 medical doctors and a lady, an osteopathic lady that work in US. I'm not sure how many of them are still working. I have received messages only from a few of them, but we never charged anything for medical doctors who came to Brazil to have a period of training. This usually takes a week, actually 5 days, on Monday to Friday. They see me treating patients, and they ask questions, and I respond to those questions as deeply as I can. But there is no charge. They have to only to deal with their travel expenses or hotel expenses, but nothing is charged by myself. I don't charge anything for that. I stopped I stopped training doctors during the pandemic, and I'm now planning to resume those trainings, but I have to adjust my schedule to resume those trainings, because you see, you have a patient in the room, you have myself, you have 1 or 2, or sometimes 3 doctors asking questions at the same time when I'm seeing those patients and prescribing to those patients. But I try to do as much as I can. Is there any other question that you had about that?
Well, when do you have any idea when you're going to resume training, and how will we know? And then how would somebody get a hold of you to arrange to come and be a part of that?
Maybe in the second half of this year. There are several issues now going on in my professional life, and related to that, I'm receiving demands from doctors who had a period of training here, and every now and then they ask questions about the cases that they are seeing. But I'm trying to do the best that I can.
Okay. So they could email you and arrange that and then you'll be able to respond and
yeah, there is during those 5 years, there is a huge list of emails that have been sent asking for a period of training. But I'm the only doctor in this clinic that is providing this clinic in English, and so it's a lot of work.
We need to train more trainers.
Train more trainers. That's a good thing, yeah. But it has to be feasible too.
One more curiosity before we move into autism. Did you see a lower incidence of COVID, severe COVID, COVID deaths among your patients who were on the high doses of vitamin D, the therapeutic doses?
In patients who were receiving high doses of vitamin D, none of them had COVID.
Oh.
In patients who were receiving what I consider the normal dose of vitamin D, which is 10,000 units for someone who has a normal body mass index, they had only mild manifestations of COVID. There is thousands of publications now showing that low levels of vitamin D are related to severe cases of COVID, and advising supplementation of COVID. When the COVID-19 started in 2020, I advised, I even recorded a clip that was published by one of my colleagues in the Facebook in the Facebook. And he, on that video clip, I advised all patients to take 600,000 units of vitamin D immediately, and started 10,000 units per day afterwards. Some patients that were on high doses of vitamin D and had their autoimmune disorder under control, they had flares. MS patients had flares and new lesions when they took those mRNA vaccines. So and that was kind of disappointing, because kind of disappointment, because those were patients that were having a normal life for like 10 years, and then they had those shots, and then suddenly they have a new flare, a new lesion, active lesion. And we had to deal with this, and that caused us a lot of problems. That was one of the issues that increased the amount of work and contributed to stop receiving other doctors for a period of training in our clinic.